to you. She is in our Department of Medicine. She also runs our Geriatric Evaluation and Management Clinic over at the VA, where we essentially screen and see all of the veterans over 75. And you can imagine that's quite a challenge given the fact that so many of the veterans in the United States, right, so many old men are veterans. I think it was just a few short years ago where 63% of all of the men who were over 65 were veterans. And that presents a completely unique challenge, as you can imagine. And as we had some of the folks talk over the past couple of days about cognitive things, and they kept referring, and Dr. Horton will talk about, and Dr. Horton, well, this is the talk about, finally. And it'll be very interesting. I think you'll enjoy it. Thanks a lot.
Oh, thank you. Okay, so the name of my presentation is It's Not Just Alzheimer's. We will be talking about Alzheimer's disease, but there are lots of other diseases out there as well that I think you will find interesting. So after this talk, you should be able to know why should we care. You should be able to know the definition of dementia, what is dementia, and also what are the common types of dementia and features of each. Dementia typically occurs in persons older than 60 years and above. Typically, once in a while you will hear in the news, or we'll have a younger patient come into clinic, less than 60. It's rare, but it can happen, so you just have to keep that in the back of your mind. It affects about 4 million people in the United States currently, but as we all know, with the baby boomer population and our population becoming older and older, that 14 million people will have Alzheimer's disease alone in the year 2040. So as you can tell, it is a big problem. And as I'll talk about in the next slide, it's an expensive problem as well. And not only does it affect the finances, but it affects the finances in lots of different ways. Loss of caregiver and patient productivity, so the extra years that they'd be able to work and to function, they're not able to do that. Then you have the cost of medical care. Medical care is very expensive. These patients should see doctors on a frequent basis, and they're also high utilizers of the emergency room as well. And there's also a high incidence of depression and medical problems in the caregiver as well. So it's exponentially affects everyone. And then the cost of nursing home care. Nursing home care costs $35,000 to $45,000 a year. And Medicare does not cover long-term custodial care. So about 48% nursing home care is private pay, and the rest is through Medicaid. Very expensive. I couldn't afford $35,000 to $45,000 a year, just for a nursing home. I mean, and you're talking about patients who are on a fixed income. I mean, that's just an enormous amount of money. And so inclusive cost is for the United States is about $100 billion a year. And I assume, or anticipate that number will continue to rise and rise and rise with inflation and the cost of everything going up, gasoline, etc. So cost will increase. So the impact on the caregiver, like I said, is not only a financial burden, it's an emotional burden. It's increased stress. These caregivers who come in with their loved ones are very stressed. And that's something that we also have to take into consideration when they come into the clinic, because if they're stressed, you know that the patient may not be receiving the optimal care. And it's just because of their condition. It's not necessarily because they don't love them or want to help them or give them the best. It's just the circumstances. I think it's very difficult, and I really admire the caregivers that are able to take care of the patients. They do a great thing, but you also have to keep in mind that they are stressed. So they have a decrease in quality of life. The things that they were able, to to do, they're not able to do anymore. Like, go to the grocery store. Well, now they have to worry about, well, what are they going to do with, dear old dad who can't stay home alone? Or, if they want to go out or, to a movie or with a friend, they have to think, well, who's going to watch, dad while I'm gone, etc. And there's an increased incidence of depression for, all of the above reasons. So for the patient, it's also a big toll on the patient as well, because they have a functional change. They mourn their ability not to do things that they once used to be able to do, like drive, or they're not able to mow the lawn, or they're not able to give themselves a shower or a bath. And these may seem like things that we take for granted, but these are big, big changes in their lives. And a loss of independence. They're not able to go and to do the things that they once used to be able to do and enjoy. And then they have a very high incidence of depression as well that you have to take into consideration. So now I'm going to switch gears and talk about, what is the definition of dementia? And part of the definition of dementia is the definition of executive function. And this is one area that I kind of was the light bulb for me when I did my geriatric fellowship, and I actually did some research in this area, because it really explains a lot of why people function the way they do. Patients with dementia, or patients whom don't have dementia, but you should really screen for dementia. And so we're going to talk about the definition of executive function. This is the ability to perform complex, goal-directed behaviors and adapt appropriately to environmental cues and modify behavior based on changes in the environment. So let me give you some examples of executive function. One is if you're walking in an emergency room. If you walk into an emergency room, there's all kinds of activities going on. You've got all these monitors going up, you've got nurses running around, you've got doctors running around, you've got patients and their families all around. So it's a very busy place. And so let's pretend you're a student and you walk in and you're supposed to go see this one patient. Well, you're able to focus in and to go see that patient. But somebody who doesn't have executive function is not going to be able to suppress all the stimulus of all the hurrying and scurrying around. So they're going to get distracted by all the monitors, by all the nurses scurrying around. They're not going to be able to shut all that off and go take care of that one patient. Another example is driving. This is my favorite example. And this is true. I was like, wow. We're actually seeing a patient, and this was his wife who did this. She actually was driving on Loop 410, and I guess she got off on the exit. And there's tons of construction around on 410. And so she comes to one, a barricade. I don't know how she got there, but she came to, one of those barricades where she couldn't get off on the exit. So she didn't know what to do. And so she just sits there for a couple hours until I guess they remove the barricade or something. So that's an example of executive function. The point is she's not able to go around. She can't use environmental cues to be able to complete her task. So in other words, like if that happened to us, we'd figure out a way to go to HEB without being able to create a new way to go without just going our same old way from A to B. And so that's also an example. Cooking takes multiple steps and behaviors. If you think about it, you have to go to the store, you have to plan what you're going to buy at the store, you have to buy at the store, and then you have to perform a sequence of tasks in order to make your meal. Finances, that's also one in which you have to be pretty orderly and structured when you're doing your checkbook and whatnot. Following medication regimen, this is a big topic for us. Our patients do not take their medicines. And it's not because they want to get diabetes and lose their arms or lose their legs from a diabetic ulcer. It's not that they want to have a stroke or nobody wants that, but it's because they're not able to follow the medication regimen, because they're not able to because of the lack of executive function, which this area resides in the frontal lobe of the brain. Making and keeping appointments as well. So keep in mind this is just one part of the definition of dementia. So what is the definition? So it's the development of multiple cognitive deficits manifested by both memory impairment and one of the following: aphasia, which is a language disturbance; apraxia, which is the inability to carry out a motor task even though your motor is intact. So they're able to move their arms and legs, but they're not able to, for instance, if you ask them to pick up a piece of paper, they're not able to do that. Or if you say, well, how would you put butter on a piece of bread? They're not able to show you how to do that. That is apraxia. And agnosia is that they can see, but they're not able to name an object. Like, what is this? Well, that's a Sprite. They can't do that. And then executive function, like I just mentioned. So they have to have memory impairment in one of the followings I just discussed. Then they also have to have impairment in social occupational functioning. And this has to be a change from previous level of functioning. And it can't be due to another medical or psychiatric illness. So key things: you have to have memory impairment, you have to be impaired in social and occupational functioning, and it has to be a change. That's the criteria for dementia. So let's say it kind of in a different way. To be demented, you have to have cognitive impairment, you have to be disabled. The cognitive impairment must be causing the disability. So here's some examples of non-reversible dementia, which we'll talk about. Some of these we will: Alzheimer's, Lewy body dementia, vascular dementia, progressive supranuclear palsy, Parkinson's. There's also primary AIDS encephalopathy and Creutzfeldt-Jakob dementia. And then you have the examples of reversible dementia. For instance, hypo and hyperthyroidism. And not all the time are you going to, depression, drug toxicities, vitamin B12 deficiency, NPH, and tertiary syphilis. So even though you diagnose and you treat these, for instance, NPH, which is normal pressure hydrocephalus, more often than not kind of stabilizes, or vitamin B12 deficiency, you're just kind of stabilizes. So you may not, this may be in addition to another dementia. So in less than 5% of dementias are reversible. The literature says about 5 to 10, or probably about 1 to 10%, but in my experience, it's probably less than 5, not a whole lot, even though it's important to look for that. Okay. So now that we've talked about dementia, let's talk about what's normal aging. So we kind of know what's abnormal, but what is normal? So normal aging is when an older person has memory change that occurs. The person is slower in learning new information, and it's not a progressive, and it's not a disabling feature. So they're just a little bit slower. So let's talk about some examples of normal aging versus dementia. And these are actually, this is actually from the Association of Alzheimer's on the website. And these are kind of 9 questions or 9 kind of domains that should be like red flags for if a person has this, then you should think, this is not normal. I should take them to a doctor. And so the first one is daily task memory. So somebody that has normal aging would be forgetting a name of an acquaintance. I do that. My husband forgets our neighbor's name. I'm sure you all do that too. Versus forgetting your close relative's name. So sometimes we probably would like to forget that, but it's not normal to be able to forget that. So something else that would be normal would be forgetting to pick up milk at the store. I mean, how many of y'all forgot to pick up milk at the store? I'm sure at one time or another. I'm sure everybody has. But it's not normal to just cook a meal and then forget to serve the meal. So that's, associated with dementia. And orientation. Everybody, forgets today's date. But it's not normal to get lost when you're going to the store, if it's a place you've, gone before. And then normal aging can be associated with like losing your car keys versus if you put the iron in the freezer or you do, leave the stove on, things like that. That's not normal. So judgment, we all forget to dress, for wintertime or if it's going to be a cool evening. You may forget to put a light sweater on. But it's certainly not normal if you see somebody walking through the grocery store in their bathrobe. So I'm sure people may have seen an individual do that once or twice. Difficulty balancing a checkbook. That can happen. But it's, inability to do basic calculations, that shouldn't really happen. We should be able to perform the basic calculations. Most people should be able to do that. And then finding the right word. Once in a while we, forget what we're going to say or forget to find the right word. Whereas in dementia, forgetting simple words, like they'll say, what is this called? I can't remember. That's not normal. Mood and behavior. It's okay to get sad and down when appropriate, but a person who gets, cries for absolutely no reason without a good cause, that's concerning for, dementia. And personality changes. As we get older, we may have a gradual change as we age, but in dementia, a sudden change should really be investigated as to what's going on. And then normal aging, initiative, you kind of have lack of initiative. You get tired of housework, social obligations. Gosh, I get tired of housework now. And then a person with dementia is a sustained lack of interest. So they used to love going to play golf, and now they don't have a thing to do with golf. And that's just, it's just not them. It's just something's changed about them. So these are kind of some features that you should think about if you should see this in your patients or, in your loved ones too. So how do we work up a patient for mental status change? Well, first of all, we get a really good history. We get not only information from the patient, we also get it from caregivers as well. And we get information about their social, what are their social support status is, who lives with them, what do they like to do, etc. Their functional assessment, which is the activities of independent living, and I have a slide on that, the next slide. And also a medication review. You have to think about some medications can cause memory loss in the elderly, so you have to really go through that carefully. And then a thorough physical exam. Hearing, maybe they can't hear you, or seeing, you want to make sure that their vision is good. You also want to do, besides the heart and lung exam, which everybody has down for a while, you want to make sure that their neurological exam is intact as well. And then the mini mental state examination and the CLOX, which we'll talk about. And laboratory data, such as those reversible dementias, vitamin B12, you want to check their thyroid, obviously check their chemistries to make sure that their sodium is okay. So you just want to just make sure that they don't have a metabolic reason to, have memory impairment. Or you want to look at their, complete blood count to make sure that everything there looks good. Other things you can do or consider, depending upon the circumstances, are some type of neuroimaging, like a CT scan of the head. That you can do if you can't figure out why they have dementia. Or it's also very good to do it as a screening tool, which is what we do, just to make sure they don't have the normal pressure hydrocephalus. Whereas it be, remember, you want to try to figure out if there's a reversible type and try to stop the progression of it so that this person is not, doomed to having, to kind of being on the downhill course. Because you remember how expensive this disease is. You can consider doing like a lumbar puncture, looking for seizures, etc. But typically with the good history exam and the cognitive screening, those are all appropriate. So when I talk about functional status, what I want to talk about is like their activities of daily living, which is what we do in geriatrics to screen. So the basic activities of daily living are self-care. And as you can see, it spells the mnemonic death. Dressing, eating, ambulating, toileting, and hygiene. These are very simple things that, like I said, we take for granted, but this is what you want to make sure that an older person's, able to do. And it's always good to do this their first visit with everybody so that you can get a good idea of their level of functioning. Patients who can't do basic activities of daily living, more likely than not, are in a nursing home. Yeah, or unless they have a really good support system, maybe. Instrumental activities of daily living are examples like shopping, keeping house, doing your finances, food preparation, and transportation. When you go through this list with a patient, it's important to say, for instance, finances. Well, have you always done the bills for your family? And if they say no, then you can, say, well, that's not a change from a baseline. So keep that in mind. For instance, the men may have never done housework, so you don't want to count that against them because it's not something that they've ever, done before. So the mini-mental state examination is a bedside assessment for general cognition, and it has been 30 years now since this was developed by Dr. Folstein. And when he did this back in I believe it was 1975, he wanted a test that physicians and other staff could give to the patients. Because at that time, the neuropsychological testing that was done took hours. And it took, an enormous amount of training, books that much just for one test. And so he developed this, and he didn't realize how popular it was going to be. And this is the most widely used test. Most people know about this. It's 30 items. It takes less than 5 minutes. They test orientation, like where are you, what state are you in, what city are you in, registration and recall. I'm going to tell you 3 objects. I want you to remember them and repeat them back to me. Robin, carrot, green. Attention and calculation. Can you spell the word world backwards? And language, can you, tell me what this is, etc. And so a score of less than 24 out of 30 is suggestive impairment. Studies done at the Air Force Village say for a person who's college educated, less than 27 should kind of be a red flag to let you know something's going on. So next is, what is the CLOX? So the CLOX test for executive function, CLOX 1, and that's where I just give the patient a piece of paper and I'll say, with the following instructions, draw me a clock that says 1:45. Set the hands and the numbers on the face so that a person can read them. So they draw a clock, and you think, well, how silly and simple. Not quite so. Some patients cannot draw a clock, and you ask yourself, well, why a clock? Well, a clock is universal. We're actually having a visiting professor from China, a geriatric professor, rotating through our department. And I was giving this lecture to a group of residents, and we were talking about the clocks, and I said, look, Dr. Wong even has a clock on, and it looks like our clocks. So it's a universal symbol. That's why we use that. So there's a 15-item scoring system. It's real quick. It takes less than 2 minutes. A score less than 10 indicates executive impairment. CLOX 2 is where you actually draw the clock and then they copy it. That actually correlates real well with the mini-mental state examination. So a score less than 12 indicates general cognition impairment. So let's do a case. So this is going to be a normal aging or dementia. So an 80-year-old comes to your office for an initial evaluation. She complains about having memory loss. Over the past year, she's noticed she's slower when learning new information and often misplaces things. She becomes frustrated because in some social situations, she has trouble recalling the names of acquaintances. She lives alone and is able to complete her activities of daily living independently. Her examination is normal, including hearing, vision, and neurological tests. Her laboratory work is normal. She scored a 30/30 on the MMSE, which is normal, and a 13/15 on the CLOX 1. So what's the diagnosis? Normal aging, right? Normal aging, because she didn't have any impairment in her activities of daily living, and she just forgot, kind of some things that I'm sure we can all see ourselves forgetting. Okay, so let's move on to mild cognitive impairment. So this is not dementia, it's mild cognitive impairment. And I'll tell you why in just a second, why it's not dementia. So it's complaints of isolated memory loss with verification on testing. They have no impairment of daily activities, which you have to have in order to have dementia. And then half may progress to clinically significant dementia within the next 4 to 5 years. So as you can tell on this scale, it shows that as the years progress, people may progress to dementia as well. And here's another graph that shows that. So as they become older, there's more of a likelihood that they are going to be diagnosed with clinically significant Alzheimer's disease. So that's the significance of mild cognitive impairment. So let's move on to dementia. This is my favorite slide. Superman in his later years. And he goes, dang, where was I going now? So probable Alzheimer's disease. Keep in mind the definition of dementia, which we talked about. They have 2 or more areas of cognitive deficits with progressive deterioration over time. This is confirmed by testing, and there's no other explanation for it. And they may have a risk factor, which is female, their age, family history of Alzheimer's disease or Down syndrome, and head injury. And some features are paranoid delusions, depression, and anxiety. Paranoid delusions, like my wife is cheating on me, is a common one. Or my neighbor stole my, silverware. So the course is early. They have orientation and attention deficits, financial mishaps and depression, and kind of mental disease. They may have some language impairments as well as motor ones as well. And then later, that's when they're, more likely, mid to later is more likely when they're in a nursing home. They have psychotic symptoms, they're delusional, they're depressed, they're anxious and agitated. And in stage, they're bedridden, mute, and rigid. So this is a nice graph that talks about the different kind of stages through time. And as you can see, it's a downhill course. So let's do another case. So this is a 71-year-old male who comes in with 2-year history of forgetfulness that began insidiously and has progressively increased. He forgot about a weekly golfing outing and a doctor's appointment. He was our no-show to the clinic. He drives, he does his finances, and he performs all other activities of daily living. He does not have any insomnia, anhedonia. Medical history is heart disease, blood pressure, cholesterol, and gout. And his medicines are appropriate. So physical exam, he's just got a mild blood pressure. He's a little overweight, and he's got some reduced pulses in his feet. His score is 26 over 30, and he fails to recall all 3 items after a 5-minute delay. His CLOX 1 score is 12 over 15. So what's the most likely diagnosis in this gentleman? Is it Alzheimer's disease or is it mild cognitive impairment? Right, because he was able to perform all of the activities of daily living. So you can have a patient who has some memory impairment, but if they're able to function real well, that doesn't meet the definition. Very good. So moving on, this is dementia with Lewy bodies is a subset under Alzheimer's. It's probably the most, or second to most common after Alzheimer's. Why is it not? Because most people with this disease are probably classified as having Alzheimer's. And it also has features of both. It has clinical and pathological disease overlap with, like I said, Parkinson's and Alzheimer's. And dementia as an early feature to keep in mind. So the following criteria are for Lewy body dementia. Again, you have a progressive decline. You have some Parkinsonian features. They're very, they may have a shuffled gait. They may have mass facies. They may have micrographia, which is writing real small. They may have spells, fluctuations in alertness. Everybody describes them differently. And then they have vivid visual hallucinations of animals and little people, typically. And so you have to have two of the three. So other features include loss of consciousness, falls, syncope, and they're very, very sensitive to antipsychotics. That's why it's important to differentiate this from Alzheimer's disease, as well as they can be delusional as well. So Parkinson's disease. Parkinson's disease is a progressive neurodegenerative disease with dementia occurring later. So some, I think, famous people would be like Michael J. Fox and our previous Attorney General, Janet, her name's
Reno.
Thank you, Janet Reno.
Muhammad Ali.
Right, Muhammad Ali, right. And they have a tremor at rest. I saw Janet Reno, I said, oh, she's got Parkinson's. You can just see the classic mask faces and then the tremor. And I don't even think I had heard that in the paper yet. I mean, you can spot these guys walking down the street. I was like, look, I was telling my husband, look, that patient's got Parkinson's. I mean, it's pretty, classic once you get the feel for it. They have a gait. Once they start walking, then they may start walking faster. They're very slow. Their speech may be mumbled and very low voice. They have postural instability, and then they have cogwheel rigidity, which is where you test them, and then that's what they do. A variant is Shy-Drager's disease, which is a subset of Parkinson's disease, and this has predominantly autonomic failure, so they may be orthostatic. When they stand up, they may feel dizzy from sitting, and dizziness is also a feature. So next is progressive supranuclear palsy. This is rare. So this is getting into the rare. I haven't seen a patient with progressive supranuclear palsy. If you find one, give me a call. I do think we have one in clinic, but I just haven't come across that patient. Features include cognitive impairment. They have some Parkinsonian symptoms. That's why this gets to be challenging, because as you start to notice, as we talked about Lewy body dementia, and progressive supranuclear palsy, they have some features of Parkinson's, but they're not Parkinson. So they just have a few features of it. They have supranuclear gaze palsy, which is they're not able to look downward. So stairs are a bad thing for them because they're not able to look down to see if where their feet are going. And then they have unsteadiness with falling. And then they have their neck is extended, dystonic neck extension. So progressive supranuclear palsy affects mostly their axial, which is their vertical, versus Parkinson affects peripheral, like their limbs. To think of that. Okay, so another case to differentiate between these two. You have a 68-year-old man, 2-year history of progressive impairment of gait, posture, and balance. So you're thinking, could he be could he have Parkinson's disease, or does he have just some Parkinsonian features? He has small shuffling steps, and he's fallen repeatedly. Cognitive dysfunction developed in the last 6 months, although mentation is normal. His wife describes episodes in which the patient just kind of goes blank, and he also has florid visual hallucinations. So which of the following is most likely? Parkinson's disease, Alzheimer's, Shy-Drager's, progressive supranuclear palsy, or dementia with Lewy body? Right, because he just kind of seemed to go blank, so he had a fluctuation in alertness, and he also had the florid visual hallucinations as well. Very good. Lewy body dementia. Okay. So Pick's disease, frontal lobe dementia. So if you remember when I was talking to you about executive function, and I said executive function is mostly a frontal lobe function. So that's kind of where your personality, some features of your personality reside as well. So when I'm talking about frontal lobe dementia, you're probably thinking, some big personality changes. And that's right. The prevalence is about 5 to 10%. The onset's about 45 to 65 years of age. And about half of these folks have a family history of it. And the average length of survival is about 8 years. And then on their imaging studies, they may have some atrophy, frontal and or temporal lobe atrophy noted. So these patients usually have intact cognition, and then they have impulsive, irregular behavior with little insight. So, these are the patients in which the caregiver is so frustrated. They have impaired judgment and disinhibition. They have lack of social graces, and they have minimal concern for appearance and hygiene. So let me give you an example. There was a patient who went to go see his geriatric psychiatrist, and there was a resident with him as well. So this patient just keeps coming up and says, hi, hi, hi. And so number one, when he does that, he's already said hi once. Then the other two is kind of invading the social or your personal space. So he was like within 2 inches of the doctor. So they finally get into the room, and so they're trying to, how are you doing, et cetera. And then all of a sudden, the guy just plumps down on the floor and starts to examine the resident's shoes. And apparently he used to be a shoe salesman, so he was really interested in this guy's shoes, which, is inappropriate as you're sitting there, talking. That would be really inappropriate for anybody to do, except if you're a shoe salesman in Dillard's when you're working. Another example of this is I have a patient who likes to drive his John Deere tractor. And so he gets the keys and he drives it in the front yard, and he mows his wife's flower bed down. I mean, he has no insight, and he's just very impulsive about it. And so this wife, every time she comes into the clinic, is just in tears, very frustrated because, I can't take the keys away from him, etc. I think she finally did, but as you can tell, it's just, it's really hard for them to manage the caregivers. And just irregular impulsive behavior.
Are these the people who, even if they have regular Alzheimer's but have the frontal lobe deficit part first, are the folks who make all these horrible decisions with finances?
They can, but they can also just be a part of the Alzheimer's as well. That's usually with the early stage of Alzheimer's. So can be. It could be, sure, they could have impaired judgment and just go and spend a lot of money too. So, impulsive behavior. I have to say finances is really interesting. I've come across patients who you would never know what they do with their money unless you ask them. And a good example is my husband's grandmother. And I always like to use her as an example because it's just wonderful. And my husband, being an accountant, swore he would never touch her finances because she actually goes and opens bank accounts. She'll go to the bank and she'll open an account up, and she's got 15 or 20, who knows how many accounts she has, because they've got a great rate. She's like, hey, isn't this wonderful? They've got a great rate. Well, she's also a little paranoid too, so she slips $100 bills into her books. And so, because she's, I guess, afraid of her neighbors will come and steal her books and everything. So my mother-in-law was telling me this, and I was like, oh my. A good case, and you would never know it. I would have never known unless, I had been told. And so I tell patients, families, go look, and you have to look. You have to see, do they have any late bills? Because they won't tell you. Another example is one of the pharmacy professors said that he got a call one day from a home health agency, because his mom lived in Florida, saying, we'd like to be paid. And so he's like, well, what do you mean? And she owed them $10,000. So you really have to go, and you have to really, really investigate, to see what's going on. That's something that you just assume things are going well, and unless you really dig into, you don't know. So, oh, whoops, let's see, go back. Oh, okay, vascular dementia. So if you ask somebody working at the VA saying which is more prevalent, vascular dementia or Alzheimer's, they're going to say vascular dementia. And actually, not so. We have a little skewed vision at the VA because most of our, veterans smoked, they've got heart disease, they have diabetes. So we see mostly vascular dementia. In fact, we have a clinic that's devoted solely to vascular dementia. And then we will see a few patients with Alzheimer's disease, but it's like, wow, it's an exciting thing. So Alzheimer's disease by far is the most prevalent. So vascular dementia is onset within 3 months of a stroke. They've got focal signs, so they can't move their arms or legs, or they have by imaging studies. So that's why we like to get, for instance, an MRI, because they can see subcortical white matter changes, which indicates that they've had, a small stroke that they may not necessarily, not. You can tell if you really look for it, with the subtle clues that we've just talked about. And then an abrupt deterioration. Patients with vascular dementia, instead of the downward sloping with Alzheimer's disease, have a stepwise progression. And it's a stepwise progression because they have an event and they're stabilized and they may do fine for a number of years, and then they'll have another event where their blood doesn't get enough blood flow, and then they'll decline in their cognitive status. Risk factors, like I just mentioned: age, blood pressure, smoking, peripheral vascular disease, diabetes, and renal problems as well. So you can have all kinds of etiologies of vascular dementia. It doesn't just have to be a stroke. It can be hypoperfusion, somebody going into surgery, the anesthesia decides to read a book, no, I'm just joking, or if they, whatever, the blood pressure drops during the surgery. That can be vascular dementia. Hemorrhagic stroke with dementia, small vessel disease, autoimmune vasculitis. If somebody has like a recurrent small emboli, or if they have subdural hematoma or a subarachnoid hemorrhage. Those are all reasons for vascular dementia. So what can you do? So we've talked about all these dementias. We said how horrible a disease it is, not only because of the impact on the caregiver, the impact on the patient. So what can you do? So one, you can refer to a geriatrician. There are a number of geriatricians in the community. If you're at the VA, you can refer to my clinic. That's what I would do. Geriatricians really look for this. They really screen for this. The other physician population, they are in tune for it, but sometimes you really have to ask these specific questions. I think geriatricians do a better job because this is what we do. This is our area of expertise. Then you also, once you make the diagnosis, you have to assess for depression. They have a high incidence of depression, as I mentioned, and you need to screen for that. And also driving skills. Do you want these people to be driving? No. I mean, every once in a while we'll hear about a person with dementia driving. For instance, like that patient in California who ran over those people in the vegetable market. So that was a real tragic case. Or you'll hear about the elderly couple who kind of go off. They get in their car going to the store, and then they find them in Arkansas. So you have to think about these things. The other thing is a home safety evaluation. You can actually have some staff go into their home and look to see if it is a safe living condition. Sometimes it's not. Sometimes we have patients who are living in the worst of conditions. And or you could have patients who are doing real well with their family, but perhaps they're falling. So you could go do a home evaluation to make sure that things are safe. For patients who live alone, we provide a MedAlert bracelet who are still able to live at home alone. Whereas if they fall or get into trouble, they can just press the button and then they can call 911. We had a patient with really severe Parkinson's who really wanted to live independently, and for the most part, he did okay. But we gave him one of those MedAlert bracelets just because if he fell, it just would have not been good. So, if he fell and couldn't get to a phone, so that's a nice thing to do. And then also refer them to social worker for advanced directives and financial planning. You want to catch these guys early so that they can actually plan these things. And you can talk to them about what do they want to do when they get to be where they can't make decisions for themselves. Who's going to take care of them? Who's going to make those decisions? And you want to hopefully get the family together, because towards the latter part, when they can't make a decision for themselves, if the family's not on the same page, it can be really bad for the patient. If you have a family fighting over stuff. Assess caregiver burden, like I mentioned. And also assure a proper living environment. Like I said, sometimes it's not safe for the patient to live at home, and it's your responsibility to make sure that it's okay for them to live at home. And every year we probably have to call the Adult Protective Services probably a couple times a year. And these patients are not safe, and that's our big concern. So some facility options. Adult daycare center, which is where they can give them medicines and do arts and crafts and do activities. We used to have one at the VA where the veterans all used to, celebrate Veterans Day or, share stories, etc. Just kind of a collegial time to get together while their caregiver may be working or have a little bit of time to do whatever. Senior Citizen Center, that can also be an option, but they have to obviously be a higher level functioning. A continuing care retirement community is, they have to be able to do some activities, independent activities of daily living, because they kind of live communals together. And respite care, if the caregiver needs a break, that's a good option for them for a couple of weeks. An assisted living facility as well, where they're still able to do some things, but not everything at all. And then nursing home care. Really, our goal as geriatricians is to keep the patient at the same level of functioning because, that's kind of our last resort is nursing home care. It happens, part of their disease progress is just the progressive decline. And so factors that predict institutionalization, patients who have behavioral disturbances, they're single, they live alone, their child as a caregiver is difficult on the child because I think, well, for instance, probably if y'all had an elderly parent, it's hard, I've got a little one at home and, we're trying to, take care of her and then to have, parents who, rely on you for, taking them to the doctor, getting their food, making sure they're dressed right, making sure they're safe. That's a whole other area, that would put just an enormous amount of stress. And the people who, I'm not even talking about the children who live with their loved ones, but the people who are kind of peripheral, who live someplace differently, they're still very stressed. It's just a stressful situation. So, but those children, if your caregiver is your daughter or son, that's more likely than not you'll probably be institutionalized. And then multiple caregivers, that can be a sticky situation too, where it's hard to coordinate among families. Sometimes it really works well if they, if the family gets along and are able to make a schedule for everybody, and so the burden's not just on one particular person, but on a lot of people. And then hospitalization, patients who are hospitalized lose function, at least one or two activities of daily living. They decline in the hospital. And the more you decline, the more likely you're going to end up there. And obviously high caregiver stress, caregivers who are in poor health. And if you use a lot of home care services, that's a big risk factor as well. And so I'm going to end with this quote. I cannot promise you an everlasting life, but I can promise you life right now. And that was by Bruce Springsteen. I actually found this in an Alzheimer's book. I was like, wow, that's pretty profound from one of our old-time rock and roll singers. So, does anyone have any questions or comments?
Anybody have any patients that, in particular, you might have had that have had some dementia, and you have any questions about managing their behavior?
I have one. I'm at a different office now, but so probably every 3 or 4 months he would come in with a walker, and we just lit candles, but you could just tell he never taken a bath or shower. He drove himself, and he would always tell me, I do everything you tell me every time. Yes, ma'am, every time. He could tell me he had I don't know if he brushed his teeth or once a week and he'd always sit there and he'd I guess he had gum that he would take out and just holding his hand the whole time.
Oh, wow.
So I never knew if anybody looked after him, or I was pretty close right out of school, so I didn't really know what questions to ask him, or, and the office had been seeing him forever. So.
For a long time. Yeah, that's hard. I know that's really hard. They tug on your heartstrings when that happens, but we try to get a feeling to see who, takes care of them at home. Do they have any family? And it's really difficult if they don't have any family.
Nobody would ever come
It's really, right, it's really hard. And these patients can be extremely vulnerable to, outside people, who take advantage, can take advantage of them as well. But I think one point I didn't make but would like to now is patients who are executively impaired or who have dementia, if you notice that the way you talk to them, you realize that you have to talk to them like they're a child. You kind of feel like you're talking down, you may talk down to them. And it's not that you're talking down to them, you're just trying to kind of get on their level. But if you ever have to do that with a patient and you realize all of a sudden that you're going down and you're trying to use very simple words and you kind of feel like you're having to treat them a little bit like your, child, that's a big red flag to me that this patient's executively impaired. We did a study at the university hospital and we found out 50% of those patients were executively impaired alone. And that's the reason why I was a resident. I always felt like, what's wrong? These patients, don't ever take their medicine or, understand what I'm trying to tell them. And that's the reason why. It's because they're not able to cognitively be able to do that, to accomplish that task. So.
Could you mention maybe a few of the infections that cause cognitive impairment?
Sure. You can have AIDS, primary AIDS encephalopathy or dementia. Patients with AIDS are very interesting because they do become executively impaired. They have the inability to take their medications. So that's why, with AIDS patients, they say, well, they have to take their medicine, they can't miss a dose, or if they miss a dose, then there's a risk of the infection, mutating and becoming resistant to the antibiotics. And this has been a dementia that's been, studied for a while, and it's, a real part of the AIDS process. That's the reason why these patients don't take their medicines. The CLOXs that these patients draw are just unbelievable. You look at that and you're like, okay, they really do have some, significant dementia as well. Creutzfeldt-Jakob is another disease caused by viral prion that you hear about. When I see it in the paper about a military recruit having dementia, that's when I think of Creutzfeldt-Jakob disease. It's very rare, and it's an extremely fast and progressive dementia. These guys are, really young. It's not a typical presentation of dementia. We typically get excited over these dementias that occur in the young patients, that occur progressively fast, that are not the typical course, like the vascular dementia or the Alzheimer's disease. That dementia is typically diagnosed, can be with an EEG. It's got typical findings on that, as well as a brain biopsy. But you can't get anybody to do a brain biopsy on Creutzfeldt-Jakob because of the fact that it's so infectious. So it's just, again, a clinical diagnosis like Alzheimer's. Like, really, it's on the slide it said probable Alzheimer's because the real way to tell if it's a definite Alzheimer's disease is through biopsy. And is it going to change your management? No. So that's why we don't do that. We don't do brain biopsies per se. So, okay. Any more questions? Okay. Thank you.